Good morning, everyone. Thank you for the invitation to present on the MRI pathway. Today, I'm delighted to be here at the ESUR 2025 Symposium in Stockholm to discuss this important topic, the MRI-directed prostate pathway, getting it right. Over the next 20 minutes, we'll explore how we can refine and optimize this pathway for better patient outcomes. These are my disclosures. You'll see that I may include discussions on the non-guideline use of MRI. So over the next few minutes, I'll give you an update on the performance characteristics of the current version of PI-RADS. I will distinguish the pathway benefits of the MRI-alone pathway from those of a risk-based pathway, which additionally considers PSA values. I will discuss the prerequisites for an integrated MRI-based prostate cancer diagnostic pathway. And finally, we'll tie it all together by discussing the key elements of a pathway that successfully integrates risk-based thinking, MRI optimization, and clinical collaboration. So let's start with the pathways themselves. On the left, we have the familiar MRI-alone pathway. It's a binary decision. A PI-RADS score of 1 or 2 means no biopsy, while a score of 3 to 5 triggers a biopsy. It's simple, but it can be rigid. On the right is the MRI risk-based pathway, which adds a layer of clinical context. Men with a negative MRI and a high PSA density would usually undergo a systematic biopsy. In the same way, PI-RADS 3 score doesn't automatically lead to a biopsy. This stratification is usually done using PSA density, or could use family history, genetic risk, and/or racial factors. Now, even the simpler MRI-alone pathway has brought tremendous benefits, as confirmed by the VISION meta-analysis published this year. It reduces the number of men undergoing biopsy by nearly a third. It cuts down on the diagnosis of indolent Gleason grade 1 disease by 12%, and most importantly, it improves the detection of clinically significant Gleason grade 2 or higher cancers by 9%, while also making our targeted cause more accurate. So we have 4 main pathway benefits. But we must balance these benefits with potential harms. The benefits come from true positives and true negatives, correctly identifying significant cancer for treatment and correctly reassuring men who can safely avoid biopsy. The harm comes from false results. False positives lead to unnecessary biopsies and the overdiagnosis of insignificant disease, while false negatives can mean missed cancers and delayed treatment. Our goal is to maximize the benefits while minimizing the harm. To achieve that balance, any MRI pathway must be built on 5 core prerequisites. These are appropriate patient selection, robust PI-RADS-based interpretations that include a safety net, biopsies that consider patient and urological preferences, and a high-quality end-to-end diagnostic process. The MRI pathway is primarily meant for asymptomatic or symptomatic men with a reasonable life expectancy after their initial clinical risk assessment according to the 2024 EAU guideline. Multiple patient groups are eligible for the MRI pathway as defined in the EAU and NCCN guidelines. Typical patients include average or high-risk men, clinically selected, biopsy naive, with a normal DRE and an elevated gray zone PSA, typically between 3 and 20 ng/ml. Another group are men with a persistently elevated clinical risk of having clinically significant cancer despite a prior negative or non-explanatory initial systematic biopsy. However, there are fewer of these men nowadays, and increasingly we see men who experience progressive PSA kinetics or have worrying clinical findings when on a safety net of monitoring after a previous negative MRI who avoided a biopsy, or men who had a positive MRI and negative histology. Now for our second prerequisite, the interpretation itself, which is about much more than just assigning a PI-RADS score. This recent meta-analysis from Arthur and colleagues in Radiology gives us the updated performance benchmarks for PI-RADS 2.1. Based on over 13,000 patients, it clearly shows the risk stratification. At PI-RADS 1 and 2, the rate of significant GG2 plus cancer is very low, at 6% and 5% respectively. This is our rule-out zone. At PI-RADS 3, the risk of significant cancer jumps to 19%. This is our equivocal category, where clinical context becomes vital. And as expected, at PI-RADS 4 and 5, the risk is substantial, 54% and 84% respectively. This data powerfully validates the risk stratification of PI-RADS and underscores why a score of 3 is the critical decision point where a simple MRI-alone pathway may fall short. This brings us to a crucial part of interpretation, considering patient and urological preferences. Remember that there's a spectrum of patients who come to urological clinics, ranging from patients who are cancer-averse to patients who are biopsy-averse. The key feature of a cancer-averse patient is that they are very concerned about a cancer being missed, even low-risk cancers. These patients include younger men with raised PSA, men with a strong family history, black ethnicity, or known germline mutations. Typically, these patients, when seen in early detection settings, have a higher prevalence of clinically significant cancers, usually between 30% and 50%. Let's apply this to a case. A 61-year-old man, Afro-Caribbean, with a positive family history and a PSA density of 0.219. He is explicitly cancer-averse. The MRI shows a PI-RADS 3 or 4 lesion in the left peripheral zone. For this patient, given his profile and preferences, the decision to biopsy is straightforward. So we can say that he has a low tolerance for a missed cancer and a higher tolerance for biopsy harms, including overdiagnosis. Let's contrast this with a cancer biopsy-averse man. Perhaps an older man with comorbidities who is more concerned with the complications of the procedure than with a low-risk cancer. He wants to avoid overdiagnosis. For him, we might only biopsy a PI-RADS 4 or 5 lesion using a higher PSA density threshold of greater than 0.15. Customizing the pathway to the patient is key to getting it right. Integral to this is the concept of a safety net for those who avoid immediate biopsy after a good quality MRI. So what kind of men are on the safety net? Data from the rapid pathway presented at AUA this year gives us some insights. There are 2 key groups. The largest group, representing 3/4 of those monitored, are men at intermediate to high clinical risk who had a negative MRI. The other quarter are men who had a positive MRI but a subsequent negative biopsy. These are the patients who require structured follow-up. This flowchart, based on a review in AJR, shows how to manage this safety net. For a biopsy-naive man with a negative MRI, we first stratify him by clinical risk. If he has high-risk features, like a very high PSA density or West African ancestry, a systematic biopsy might still be considered in discussion with the patient. If the biopsy is negative or if no biopsy is performed, he remains in continued urological care. For the non-elevated risk man, we have 2 options. Those at average risk can be discharged back to primary care with clear triggers for re-referral, while those at higher risk continue under urological surveillance. And the long-term data is reassuring. Several prospective studies, including STHLM 3 MRI and PRECISE, show that for men who avoid biopsy after a negative MRI, the rate of detecting GG2 plus cancer over 2 to 4 years of follow-up is very low, typically between 1 to 5%, with long-term biopsy avoidance rates around 90% or higher. We can expect the RAPID group to publish their data soon, which are consistent with these figures. For those interested in diving deeper into the oncological safety of avoiding a biopsy in negative cases, particularly into the PROCOM trial data, I'd like to highlight the Bayer-sponsored symposium happening on Friday, where we will be discussing this topic further. This brings us to our third and final prerequisite, the quality of the entire MRI diagnostic process. Quality is non-negotiable. As outlined by Barrett, there are a number of checkpoints in the quality process. This means our imaging technique must be compliant with PI-RADS 2.1 standards. Image quality should be assessed, for example, using the PI-Qual scoring system. Radiologists need the right experience, and we should be looking at certification potentially, augmented by AI decision support tools. When biopsies are needed, centers should be equipped to perform them or at the very least refer patients for biopsies. Any biopsy should target the MRI-detected lesion with additional perilesional cause if you practice in Europe, or systematic cause if you practice in North America. Ideally, patients should undergo MDT review, and multidisciplinary team working, including pathological feedback for radiologists, is essential. Finally, we must monitor our outcomes using key performance indicators, or KPIs. This brings us back to performance metrics. Traditional accuracy measures like sensitivity and specificity have limitations. These numbers are subject to verification, detection, and confirmation biases because not all negative cases undergo biopsy. These measures offer relative accuracy at best. Therefore, we need to move towards measuring clinical utility. Instead of just test accuracy, we should focus on the tangible benefits and harms of the pathway itself. How many biopsies are avoided? How many indolent cancers are not diagnosed? How many significant cancers are found? These metrics apply to all patients in the pathway, not just those who get a biopsy, and this eliminates verification bias, allowing for meaningful comparisons between different centers and studies. This is a perfect example of measuring clinical utility from a study in Sweden published in JAMA. They looked at outcomes before and after introducing an MRI pathway in 2018. The results were striking. After 2018, overall biopsies fell by 16%. Negative biopsies plummeted from 28% to just 7%. The diagnosis of insignificant IgG1 cancers dropped from 24% to 6%, while the detection of significant GG2 plus cancers in those biopsied rose from 49% to 86%. These are the KPIs that truly define a successful pathway. So, in conclusion, a successful pathway is a tapestry woven from 3 threads. The first is risk-based thinking, understanding the difference between early detection and screening, and tailoring biopsy decisions to clinical risk and patient preference. The second is MRI optimization, ensuring technical compliance and quality while embracing automation and AI to support our reads. And the third is clinical integration, working in multidisciplinary teams, incorporating other biomarkers, and most importantly, monitoring our pathway's quality and its benefit to harm ratio. The MRI-directed pathway has already solved many of the problems of the old systematic biopsy for all paradigm. But now we face new challenges, optimizing who we biopsy, ensuring quality, and proving its long-term safety and effectiveness. In this regard, the PI-RADS steering committee is already working on the next evolution of the pathway, and you should expect to see an update of the PI-RADS pathway in 2025, which will be risk-based for both assessments and biopsy recommendations. Thank you very much for listening. I hope you found some of these comments valuable for your clinical practice.